Good afternoon, Senator Price and the other members of the Senate Business and Professions Economic Committee, and also to the staff. My name is Louise Bailey, and I'm the Executive Officer for the Board of Registered Nursing. And to my left is Janine Graves, who is the President of the Board, and to my right is Stacy Baruman, and she is our Enforcement Program Chief. First of all, I'd like to say the Board of Registered Nursing has been in business for quite a few years, since back in 1905. And at this point in time, we have a 9-member board, and that member board is comprised of 4 public members and 5 registered nurses. The governor appoints 7 of those members, the professional nurses as well as 2 public members, and then the Senate appoints one, and the Assembly, the Speaker of the House, also appoints one of those members. And the mission of the board, our mission is to protect the public by regulating the practice of registered nurses, and implementing and enforcing the laws and regulations in the Nursing Practice Act. At this point in time, we regulate over 384,000 registered nurses. We're getting up there, close to 400,000. Also, we issue over 23,000 new licenses annually. And also within our issuance, we issue various certificates for nurse practitioners, nurse anesthetists, midwives, clinical nurse specialists, and also public health nurses. We approve 148 pre-licensure nursing programs. And these pre-licensure nursing programs are public programs and private for-profit programs. At this point in time, we have 90 associate degree nursing programs, 39 baccalaureate programs, and 19 entry-level master's programs. The entry-level master's programs are for those individuals who would like to become registered nurses and have a baccalaureate degree in a discipline other than nursing. And many times these are individuals who are indeed changing careers. Also, we have over 3,000 continuing education providers, because the nurses in the state of California, in order to renew their license, they must have a minimum of 30 continuing education hours, and they renew their license every 2 years. And so to that, we also renew over 180,000 licenses every year, because we have the 384,000. We have a budget. Our budget is a little over $28 million, and we have been approved for 137.7 positions. Although we have approved for that many positions, we have quite a few vacancies. In fact, we have currently 43 vacancies, which makes it 31% of our staff that we are down. We are deficit, and that is what it is right now. I know in that packet you have up there, it is an addendum that you have before you that shows our staffing as a whole and our lack of staffing and the kind of additional staffing that we need in order to continue to protect the public in a most efficient way and effective way. When you look at that addendum, you will see that the total is 47 additional staff that we feel that we need. And one of the areas there has to do with the continuing education providers. We have I shouldn't even say a whole person who looks at the continuing education providers. We're supposed to audit providers and also audit nurses. But because we are so short of staff, we do not have the staff to do the auditing that we have done in past years. And to that, I'd like to say we also have a very fine enforcement program that we have. And within our enforcement program, we spend over 70% of our budget for disciplinary matters. We received over 7,000 complaints for the fiscal year 2009 and filed almost 800 accusations, and we imposed over 500 disciplinary actions. And we monitor over 450 registered nurses who are on probation. And in terms of our diversion program, this is for individual nurses who are chemically dependent or mentally ill, and we have over 500 currently in the program. And this program has had over 1,500 registered nurses who have successfully completed this program. And
back over 3 years, 5 years, 10 years?
Oh, we've been in business since the 80s. Yeah. These have successfully passed.
Okay.
Mm-hmm.
For diversion, I mean.
For the diversion program. And we will be getting into some more specifics about it at any point in time that you would like. Stacy Baruman, the enforcement manager, is going to go into some very specific details about that. It also, we have done a lot in the last several years since our last sunset. Our last sunset, as you know, was in 2003. And since that particular time, the Board of Registered Nursing, the composition of our board was changed in that we used to have a physician on the board, which we no longer have. And so we ended up with an additional public member. That's why we now have 4 public members. And we also have an advanced practice nurse on our board. And let's see, the other thing that we have improved upon is that our internet and website capabilities. We have added more information for the public to the website, and we update our website on a daily basis, including any disciplinary actions and the status of the nurse's license, and that is on the website, so that an employer, if they want to know if a nurse has a license that is free and clear of discipline, or if the person is indeed even licensed, they can go to our website. And we also have a 24-hour telephone system so that they may go to that system and also validate if that person indeed has a license. The other work that we have been doing since 2003, we have continuously approved numerous programs. We have approved over 52 additional programs during that period of time, and they are private for-profit and also public programs. We do not discriminate if they are public or for private. And I know within the background paper, we are encouraged to continue working with our for-profit programs that would like to start nursing programs here in the state of California. And as you know, we are still in a nursing shortage. It may not appear to be because we have our new graduates who are having a difficult time finding positions. But that is attributed to the economic times right now. And when things get better, we are going to see, I think, a significant difference because the population is aging and the baby boomers are going to retire. We're going to have a greater need for individuals to have nurses, and so thereby we think that is very important in expanding these programs. Also, over the years, we have participated in the Governor's Workforce Initiative and the Nurse Education Task Force in helping to expand the nursing programs here in the state. The Governor's Discretionary discretionary fund. There was millions of dollars that was funneled to the community colleges so that we could assist in expanding those programs, and that did indeed happen. We have to attribute it not just to the Board of Registered Nursing, but to our outstanding deans and directors and faculty in this state, in that how they worked very hard to expand these programs, and that has not been an easy chore because of the fact that it's very difficult finding faculty, to teach our students. And unfortunately, for our applicants who want to come and become registered nurses, we have those who qualify, but thousands of them are turned away because we do not have enough faculty and enough programs to accommodate those students. But over the years, we have really doubled the number of graduates here in the state of California. We have doubled them from, there was only about 5,623 back then, and we have over 11,500 graduates that we on a yearly basis. So we have, working together with the colleges and universities, we have indeed done well, I think, in terms of expanding the programs. The other thing is that all of our graduates in the state of California, and also individuals who come from outside of the country and come into the United States, they must take a national exam, and that's a national exam is called the NCLEX RN exam, and that exam is administered and is owned by the National Council of State Boards of Nursing. And every nursing board in the United States and its territories belong to the National Council of State Boards of Nursing for many reasons, but one of the big reasons is that that is the entity that goes ahead and they give the examination. So people who even live out of the country and they've been a nurse for several years, when they come into this country, they must take that national exam. We look to all of our nursing programs. They have the same standards, and that's how we protect the public, by making sure that we have standards for all of our nursing programs. Our programs are approved by the Board of Registered Nursing, as well as the faculty are approved by the Board of Registered Nursing. And we have nursing education consultants, and what they do, they're state employees with the Board of Registered Nursing. They're assigned to all of the colleges and universities throughout the state. And they have two primary purposes. They work with these programs, and they go out and visit these programs at different cycles, and they wear two hats. The first hat is a regulatory hat, in order to make sure that the programs are administering the programs according to our laws and regulations in the Practice Act. If we have programs that are having some issues or they are non-compliant, then the nursing education consultant will consult with them to help them to make their program so that it becomes compliant. Because the purpose of the visits and working with the programs is not to close programs, but to enhance programs and make them better programs. So that's what we do. So that's been an improvement that we have done also. Also, I want to back up to those NCLEX scores. Many years ago, our NCLEX scores for our graduates, and when they took the national exam, were a little below the national norm. But let me tell you, for the last 3 years, our students, when they graduate and they take the examination, they are a little above. I just looked at some stats for the national exam, and it was 87.2, and California was 87.4. And there has been times when we have been much higher than the national exam. So our programs are very effective in what we are doing at this point in time. Then also looking at our what we had to do just recently is that we had to increase our fees, our renewal fees. And the reason we did this was because back in 2008, we had some adverse publicity from the LA Times that said that registered nurses who had been convicted and had discipline on their license in other states had an active and clear license here within the state of California. And so after we heard that news and we looked into it, we realized what the issue was, and it was because in 1990 we got the authority to be able to require that every registered nurse who applied or had to have their fingerprints done and a background check. Well, the board, we did not go back and fingerprint all those individuals prior to 1990. So the board pursued and got some emergency regulations for fingerprinting, and with that, we had over 140,000 fingerprints that we were going to have to do. So what we did was that as people started to renew their license, because this became effective in March of 2009, as they renewed their license, then they had to be fingerprinted. And so through March of 2009, 10, and 10, 11, we just about have everyone fingerprinted. So everyone must be fingerprinted. And so we didn't get all the staff that we really needed for that endeavor. And at that point in time, we did have a staff person who was assisting with the auditing of the continuing education hours, and that person had to be removed to help with the fingerprinting because that indeed was the priority. And then in 2009, we got some more adverse publicity, and as I understand, you must have the article that had to do with the point that it was taking the Board of Registered Nursing 3+ years or so, or whatever, in order to discipline nurses. And at that point in time, yes, it was true, but it did not, the article did not say as to why it was true and why this was happening. And the reason was for that was because we were sending our cases to the Department of Investigation as we were supposed to. And in fairness to them, they did not have the adequate staff to investigate our cases as well as all of the other cases. So yes, they did go there. They did sit maybe for a year or longer. And then when they came back to the board and they were sent to the Attorney General's office, the same effect happened because there were so many cases, so they did indeed sit there. So it was a situation that happened. The department was aware of our backlog of cases. It wasn't anything that we kept a secret, and it also was placed within the Sunset Review report. And so after all of that, excuse me, need some water. When we got when we saw what was happening with that, we decided, the governor's office decided that he needed to do something with the Board of Registered Nursing. And at that time, we only had 6 board members. We were supposed to have 9, but a couple of the board members, their terms had ended, and so that's why we were only down to 6. And out of that, thank you. Out of that 6, 5 of those board members were the governor appointees. 3 of those board members, their term was up, and so naturally they did not get reappointed. 1 board member, governor's appointee, resigned, and the 5th one decided that she was going to stay on. And then we had 1 other board member who was an appointee of the Speaker of the House. So we ended up with 2 board members, and the executive officer then resigned her position because the executive officer is appointed by the board and works at the pleasure of the board. And also what happened in August, we came before this committee, and Senator Negrete McLeod was the chair at that time, so that we had talked about what our plan was going to be, what we felt we could do. And so within that, we decided we wanted to have more control over our investigative process. So we decided that we were going to have our own investigators. And we asked for 63, not only investigators, but also support staff. And so we asked for a staff of 63 so we could really do a yeoman's job. And we were only given 37. We were approved 37 staff last year, but we didn't hire any because we're in a hiring freeze. As of August, a hiring freeze. So we have not been able to hire so that we can get those cases investigated and get them moving again. So we're going to end up in the same situation with a big backlog of cases. And on that note, I'm going to let Stacy, our enforcement chief, give you some additional information.
Good afternoon, members of the committee. Just to follow up on what Louise's information that she has provided you, in addition to all of the changes that the BRN had suggested as far as improving our enforcement processes, we worked with the Department of Consumer Affairs. We also worked with the Attorney General's Office and the Division of Investigation to look at all of the processes to see how we could better use our resources, reduce backlogs, improve timeframes on our case processing. Through those meetings, the Attorney General's Office prepared and presented the Board of Registered Nursing's case movement guidelines, which they presented in 2009, of timeframes that cases would be processed as far as when an accusation would be pled, when a hearing would be requested, all of those various timeframes in the disciplinary portion of our process. We also worked with the Division of Investigation, as was stated earlier, to review all of our cases that had been backlogged for over a year, as well as any other cases that were there. In the hopes that we were going to be getting our own investigative staff, we came up with a plan for the types of cases that would be reviewed and investigated by the Division of Investigation, and then the types of cases that would be investigated by Board of Registered Nursing investigators. Based on that plan, we were moving forward with that in mind, and cases were referred to the Division of Investigation based on that criteria, while we didn't necessarily have the investigative staff at the Board of Registered Nursing. We did attempt to hire 5 retired annuitant investigators. We are now down to 2 retired annuitant investigators. We have a fairly good backlog at our office. We were at over 700 cases in our office waiting for investigation as of approximately 6 months ago. However, because of the fact that we have not been able to hire for the investigative positions, we have been working to transition all of our oldest cases back to the Division of Investigation so that they can do the investigations that are necessary in order for us to either take action or close out our cases. So we are now down to approximately 500 cases in our office waiting for investigation by either our investigators or the Division of Investigation.
And the division has how many?
Division has pending cases. The pending cases at Division of Investigation has risen as we have transitioned these cases over. We have approximately, let me just take a quick look here. As of the end of February, sworn cases, 604 pending cases at the Division of Investigation. In efforts to improve what we are doing at the Board of Registered Nursing, SB 1111 was proposed and did not make it through the process to help us enhance what we are doing for our enforcement efforts. So we are in the process now. We have proposed and have referred to the Office of Administrative Law a regulatory package that would allow us to delegate authority to our executive officer to approve settlements for revocation, surrender, or interim license suspensions. would require an administrative law judge to revoke a license without a stay order if the licensee has violated codes related to inappropriate sexual contact or offense. Require an evaluation if an applicant for a license appears unable to practice due to mental or physical illness, and criteria to deny an application or revoke a license for registered sex offenders, and also further define unprofessional conduct to include no gag clauses in civil settlements, failure to provide requested records or cooperate during an investigation, failure to notify the board within 30 days of felony charges or indictment, arrest, conviction, or other licensing-related disciplinary actions, or to comply with a subpoena. Let's see here. However, we do not have, at this point, the authority to mandate the release of medical records, which is another area that we are interested in having that authority. As far as, I want to follow up on some of the information that Louise had provided. Would you like to go on to the next section?
Yeah.
That's mainly what we've done as far as following up for the media attention from the LA Times.
You know, one thing I would like to share and add is that for licensing, I mentioned to you about all the license that we license, and you know, I would like to publicly say that I think we have one of the best staff in the state of California, and the reason I say that, they're very knowledgeable and they're very, very devoted to the Board of Registered Nursing. As one of the examples is we had a backlog of applications and for people to be licensed, and the staff volunteered to come in on many weekends. That included the licensing staff, the mailroom staff, and also the cashiering, so they could catch up on those applications so that individuals could be licensed and start work in this state. And at this point in time, we do not have one backlog of our licensing applications, which we're very proud of. But within that unit itself, I want to share with you our infrastructure isn't what it should be. Right now, we do not have an assistant executive officer. We do not have a manager for the licensing unit of 28, a staff of 28. We do not have supervising nursing education consultants, one for the north and one for the south. And we do not have our staff services manager 3 for our enforcement unit. Because of all of this is because of the inability to hire into these positions because of the hiring freeze. So we want to get our infrastructure in line, because we know within the background paper talked about our strategic plan, and we do want to update our strategic plan, but we wanted to make sure that those individuals were on board first. I forgot to tell you that I was appointed in August of 2009 as the interim executive officer, and I've only been the executive officer since November 23rd, 2010. So hopefully we can get our infrastructure together and we can go forward and look with a fine-tooth comb at our strategic plan and incorporate some of the kinds of things that we have been doing over these many years.
In addition to that, based on the staffing issues and our request for the additional staff, we also had a limited-term staff based out of the fingerprint budget change proposal that was approved in 2008-9 that is also expiring. We are working on being able to retain those employees because they have worked with us for almost 2 years now. They have a significant wealth of training and information.
In what capacity?
And they work in our enforcement program as far as reviewing the retroactive fingerprinting results. The staff also reviews, now that we are asking the conviction question on our license renewal applications, they review the responses to that and the disciplinary actions if they have any in other states. So we have that workload that is continuing on, even though we will be finished with fingerprinting the retroactive group. So that workload continues, as well as the cases that come out of that also have to be managed through the process if they go to discipline at the AG's office. So that workload continues, yet that staff, we may lose that staff in the next 60 days or so. Three staff members.
Any other testimony?
Yes. As far as addressing our ability to meet the 12 to 18-month time frame for the disciplinary process for our cases, just so we note, back in 2007, 2008, it was noted that we were taking about 1,200 days was the average time frame to complete a case from start to finish, whereas at the end of fiscal year 2009-10, we were down to 33 months, where the previous was 40 months. So with the limited staff that we have been able to add into the enforcement division, and working with the AG's office and the Division of Investigation, we've been able to reduce that time frame down 7 months. We know that there are definitely is a lot more work for us to do, but with the addition of the staff that we do not have, we feel that we'll be able to further address that so that we can get down to meet that 12 to 18-month goal. Our other issue with the hiring issue that Louise was not aware of is that when we got our budget change proposal approved for the Consumer Protection Enforcement Initiative, it allowed us to have special investigators. The Department of Consumer Affairs is not authorized to hire for that special allocation position. We are only authorized to hire the peace officer investigators. So we had to submit a package to the Department of Personnel Administration, who had to review and approve that position allocation so that we could hire. So that's where we got stuck in the hiring freeze. Was we were authorized for the positions in July of 2010, yet we could not hire for them because we didn't have approval to do so. So once the hiring freeze came on, we got the authorization in January of 2011, and we're in the midst of a hiring freeze and we're not able to hire for any of those positions. We are, however, recruiting based on our limited transfer options within our department. So we hope that we'll be able to fill a few of those positions with staff members from other boards and bureaus within the department. We have some suggestions for improving the time frame for disciplinary cases and the quality of investigations and access to information. In addition to the staffing, we are interested in lowering the burden of proof from clear and convincing to a preponderance. There are 34 other states which license registered nurses where preponderance is the burden of proof. We are also considering would be interested in allowing the BRN to hire at least one full-time attorney to work with enforcement to better develop investigative requirements to meet the burden of proof, oversee staff who can prepare less complex pleadings in our accusations and petitions to revoke probation, and oversee staff who could prepare default pleadings. We are also interested in the authority to issue warning and educational letters, which we do not have currently. This will give us an additional tool which does not result in formal discipline, yet is a lower level of discipline for licensees whose violations don't rise to the level of a formal action. We are also interested in the authority to issue a letter of public reprimand or reproval without the filing of an accusation. We would not have to refer those cases to the Attorney General's office, which could thereby reduce the time frame that it would take to take an action against a license. Because of the backlog at the Office of Administrative Hearings, they need to be able to hire additional administrative law judges. We're not certain if there's any other ways to get around that. The hearing dates right now for us are being scheduled anywhere from 4 to 9 months out initially, and case continuances are granted on a regular basis, which extends the process even further. Either that or to consider an alternative form for less complex administrative hearings to be heard in front of a hearing officer, or that the Department of Consumer Affairs be allowed to have its own administrative law judges. We, as well as Office of Administrative Hearings, the Attorney General's Office, with the tremendous caseload from our board as well as other boards, even though they have reported very good timeframes for pleading our cases, they too must be authorized to hire additional attorneys and legal analysts in order to keep up with the increasing caseload. We are interested in the authority to draft less complex pleadings under the direction of a DCA or BRN attorney, thereby reducing that workload at the AG's office, where they could focus on the more complex cases and be able to resolve those cases more quickly. We would also like to improve communication and have the ability to share investigative materials between various state agencies that interact with our licensees, which could thereby reduce duplicative workload for those agencies as well as us if we could rely on an investigation at another agency. We are also interested in doing amongst ourselves is utilizing additional outreach options, which we have not been able to do in several years, to the various health-related organizations and schools to better educate them about the disciplinary process, and hopefully they would learn more so that they wouldn't come into our disciplinary process. As far as difficulties that were still occurring in the investigation stage, we have been working with the Division of Investigation, but because we changed the structure of how we process our complaints and investigations, we now only have one person that is monitoring the cases at the Division of Investigation, and it's difficult to keep up with the follow-up that needs to be done on the over 600 cases that are over at the Division of Investigation. We'd like to be able to increase training opportunities between the Division of Investigation and the Board of Registered Nursing to better educate the investigators regarding our cases. We think it would be good to conduct a study to determine if the Division of Investigation could be better utilized by specializing in healthcare-related or business license cases, instead of the investigators investigate all 37 different boards and bureaus types of cases. The BRN and the Division of Investigation Management have been working much more closely than we had in the past as far as improving and increasing our regular communication to help eliminate these issues as they come up.
Does that include the Attorney General's office? Or what discussions have you had with the Attorney General's office?
We have had discussions with the Attorney General's office. We have had a few meetings with Alfredo Terrazas. We have also instituted, when we have board meetings that are in a location where it's close to an Attorney General's office, myself and another enforcement manager or the probation manager go out and actually meet with the staff and the supervising attorneys to discuss what issues that we are having as well as the issues that they might be having, so that we can they can know what our priorities are. We can put faces with who we are and improve our working relationship. But we also have, in addition to that, we do have discussions with them, and we just recently started receiving electronic billing data from the Attorney General's office as of, I believe, November of 2010. However, because of, as Karen had mentioned earlier, their system and our system don't communicate well, and it's hard to get their information and our information to put it together, and their dates don't always add up to what our dates match up to be. And so we're interested, because our Attorney General's line item has increased so dramatically, as far as our expenditure was $3.4 million for last year, and we're projected to spend over $6 million this year based on the number of cases that are over there, to better get a handle on what the costs are associated with prosecuting our cases at the Attorney General's office. We do know that, which we didn't know before, is the minimum rate that the Attorney General's office charges us is at a 15-minute increment. And so we have concerns with the fact that we're being charged 15 minutes to read an email or respond to a telephone call, when it might not necessarily take 15 minutes.
Well, what's the alternative?
Well, charging at a lower, say a 6-minute increment versus, I mean, not necessarily down to, the exact, but a lower increment to better disseminate the charges. Being that we're the largest client, I would imagine we get the largest charge for the cases. We're hoping, though, that with the Breeze system that will be coming up in hopefully 2002, that it'll help alleviate some of these issues. Let's see. The background paper addressed giving us the authority to obtain the medical records and various other records from the courts and law enforcement agencies. We do consider that those additional changes to obtain that information as vitally necessary for us to be able to do a better job of knowing when things occur. We do get our subsequent arrest notifications from the Department of Justice. However, we've learned recently within the last year that the information, even that the Department of Justice provides, isn't always 100% accurate. We have applicants that disclose that they have convictions, yet we get information from Department of Justice that says they don't have any convictions. So we're relying on a system that may not be completely accurate and relying more so on our applicants and licensees to disclose that information. Our other issue would be is that the FBI is a one-time fingerprint. We get, at the time that they do fingerprints for us, they do not have a subsequent arrest notification. We did have a meeting with the FBI last month, and they are working on coming up with a way to do that, but he didn't have any idea as to how long that might take for the federal government to come up with a subsequent arrest process.
And also, the FBI did an audit on the Board of Registered Nursing for the fingerprinting, and we passed it. With flying colors.
Another issue in that vein is that we are being charged by at least one law enforcement agency in Los Angeles to obtain arrest records. And that delays our process in that we have to get a purchase order and then send that down and then wait for the records to be provided to us. So that delays our process as well. If there was a way that because we do quote in our letters that request information that because we are a regulatory agency, we should not be charged. However, we are charged in some circumstances.
Well, why is that still a problem? I mean, either they are or they aren't.
Charging for the records?
Yeah. Why are you charged sometimes, and sometimes you're charged, sometimes you aren't charged? Is that what you're saying?
Well, no. LA County charges.
Right.
There are almost all other counties do not.
Oh.
So
well, LA County is a problem.
Yes.
We have to pay.
Yeah, thank you.
I don't know with the financial situation. I don't know that LA County might not be the only county
sure they
that
have
would
a
be
good
charging
reason.
for this.
What did we charge you?
So that does hamper us since we do have a large number of our licensees in the LA area, and that information coming out of there delays our process as well. Let's see here. Asking about workload with these additional reporting requirements to the board, it's unknown how much of an increase this would provide to us of workload. We're hoping with the subsequent arrest notifications from Department of Justice, we don't always get subsequent conviction follow-up. In fact, our arrests are the majority of what we get. It's rare when we get follow-up that there's been a conviction. So if the courts are required to notify us of convictions, we think that would be extremely helpful. And if they do at the time, if they would provide the certified court records to us, that would even be a better benefit because we wouldn't have to subsequently request that information after we've been notified. We would have to review, based on the reporting requirements, what type of workload that might create for us, though. It's asked as far as mandatory reporting of suspended or terminated nurses by employers. As it is with vocational nursing, or an option of a nursing peer review. We have had discussions about mandatory reporting at our board meetings and committee meetings. We haven't come up with a formal policy as far as whether or not we would pursue that. We are open to it, but we just don't have the staffing resources to deal with that workload that would create. However, the nursing peer review is an option that has not been discussed, and we would be happy to take that to our board members and discuss that as an option for reporting actions which occur in the health facilities. Can we go into nursing?
Diversion.
Do you want to do it now, or do you want to do that?
You might as well do it now.
Okay.
That's more important. with our time's running out.
Okay. We know that there are concerns that the committee has as far as the Board of Registered Nursing's diversion program, and it was asked whether or not we could better determine the success rate of the program rather than counting just the number of successful participants. And according to the National Council of State Boards of Nursing, who's done extensive research on diversion programs, in addition to that, they use additional criteria as far as how many referrals there are to the program, and California has one of the highest in the country. Whether or not a program is able to quickly remove a nurse from practice, which we are as soon as they enter the program, we're able to remove them from practice, or if they test positive for a banned substance, they are also removed from practice. Also, whether or not relapses are identified. The Board of Registered Nursing receives quarterly reports identifying relapses of all program participants, and during the quarter ending December of 2010, there were 15 out of 668 participants who had relapsed, which is a 2.2% relapse rate. For the quarter prior to that, ending September 2010, there was a 4.4% relapse rate. And this was after we had started increasing the testing levels, as is the recommendation out of SB 1441, where our new applicants into the program who initially are not working were being tested 18 times. They're now being tested 24 times, or as needed, as far as where they are in their recovery process.
So is the board generally satisfied then with the diversion program run by Maximus?
Yeah.
That's are you overall satisfied with the program? We've heard some criticism of the program and how it's how it impacts other agencies and boards. Is the Board of Nursing satisfied that it's doing a proper and appropriate job in identifying problems and serving the public, saving the public in some cases?
The Maximus portion of the program, Senator, is just one portion of the program. We rely quite heavily on our probation monitors. Our monitors know these nurses. They know their supervisors, and they'll be the first one to test you after Super Bowl Sunday. So we like the randomness and the frequency that we assign to each person. Each person is different. Some people require heavy testing in the beginning. Some people require less testing. We know these people pretty well, and we're trained and alert to any concerns that may require additional action. These, when I read the cases, the probation monitors are very strict in the board, and there's a high index of suspicion at times, and they act on that. And we're very comfortable. As you can see, we've done a post-mortem on a lot of the problems that we took a fresh look in July of 2009 when we came on. We were all new, and Louise was thrown into this as well. You know, out of adversity comes opportunity, and we had the opportunity to take a critical look at everything, and that can be a very eye-opening and honest experience. And from that, we are one of the more transparent boards. We've heard lots of public comment. The Board of Registered Nursing is so transparent. There's lots of public comment. Our constituents, senators, are all the people of California, the children, the adults. We're with you when you're born, and we're with you when you take your last breath. So we have a vested interest in our quality. And we've spent a lot of today listening to 0.1% of all nurses that have troubles. We also abide by the law. Nurses do have due process, and we have to do the right thing for our nurses because they are also citizens of the state of California. So that is why we're very careful, and we try to adhere to the rules of the state, and we are the first to take people out that have problems.
Yeah, you know, we certainly share the caution. We want to respect the right of every citizen for due process, but we certainly want to protect citizens as well from professionals who may be having some difficulties. Yes, Senator McLeod.
I think your terminology would be better than you say you take people out. You remove them from their jobs as opposed to...
Yeah, that's one thing that we do. When they come into the program, they have to cease practice. So they are not practicing. They do not go back and practice for maybe 9 months or a year until they have to go through the diversion evaluation committee. And as they indicated on that committee, there's a physician, 3 nurses, and a public member. All of these individuals specialize in chemical dependency and mental illness. And what's so great about the deck is that every individual on that deck has an equal vote. It can't be just the doctor who decides what is to be done. They have to all, there has to be a consensus.
No.
Yeah.
I'm talking about the term.
Oh, I know, yeah.
Take 'em out.
Yeah, take them out, yeah. I understood. But I had a chance to I wanted to bring up that particular
She's
issue.
trying to help me with my directness. As you can see, I'm not a political person. I've been a nurse for 30 years, boots on the ground, direct patient care, and we can be rather direct. I just want to give you an example. When I was working about 15 years ago, a nurse that I didn't know very well, she apparently was in the diversion program, and she was removed from the operating room. And when she returned 6 months later, she was very strictly monitored. And 2 years later, she ended up being my supervisor. So I've seen lots of success stories here in my employment. And I've also seen that nursing is quite an investment in time, training, education, and we all benefit from that. And some people out there are vitally important to support. And that's why we believe in it. Would it be easier not to? Yes. Would it be the best for the patients? No.
Well, yeah, we appreciate the comments. We want to focus. The next panel is going to focus on issues related to nursing shortages, workforce diversity, some issues you touched upon. But I do want to, before you leave, just get a little better clarification on what we're doing in terms of approving new programs. What's that approval process like for nursing programs? How are we providing the kind of guidance, if you will, the kind of oversight, the kind of assistance in that process as it moves forward?
Well, when an entity would like to have a nursing program in the state of California, what they do, they submit a letter of intent. And this process is, everything is up on the website, so they know, they can look at it, and they know each of the steps they have.
I guess my question is, are we doing anything differently? What are we doing differently to accelerate the process, to make it more transparent, to make it more user-friendly?
Well, what we did do this past time, when we updated our education regulations, we were very specific in there about what new programs needed to do and how to do. And I think that will make clear up some of those kinds of things. And also what we did is that sometimes new entities, they may need some assistance in terms of really developing their program. And so I contacted the president of the Association of Associate Degree Nursing Directors for the South and for the North, and asked them if they would compile a list of consultants or individuals who could possibly help some of these programs. So because many times the programs, they want to start a program, but they don't know really how to start the program. They may not have that expertise to do it. And so thereby they can now contact one of those presidents and see if they can indeed get some assistance for their program.
This is
new programs.
A consultant that is usually hired?
Yes, yeah.
Into the process,
yeah, they're hired. They're not our consultants for the state. No, they hire an outside consultant. Many times they will hire directors who have retired and ask them to come on board and help them with their program and to develop their program. And what they do, they have to have a feasibility study, and the board approves that feasibility study. That's like building a house. You got to have a foundation, and so the board approves that. And then the next step is that they must do what we call a self-study. And that self-study comprises the entire program, even the curriculum that they're going to be giving to those students, as well as all the clinical sites. And the curriculum, the clinical, must meet our educational standards. So there isn't any difference.
Are there some recommendations, though, about accelerating that process, speeding that process up?
The only way it can be accelerated is dependent on the person who who wants to have the program. So let me tell you what happens. Many times if we get a letter of intent, we don't hear from them again for maybe 2 or 3 years. Okay? Then again, we may hear from them. They do a feasibility study, and once again, they may wait before they get get someone to help them to develop the program. So it depends. The program determines how long it is going to be and how long to streamline the process. And then some programs, they come through and they do very well. We have for-profit programs who have come to our board meetings, sat through our education committees, and the whole bit, learning what to do, how to do. And when they come before the board, usually it's a very smooth process, and they get through it much quicker than those who do not. Yeah.
Mr. Emerson.
Thank you, Senator. Ms. Graves, I have a question dealing with nursing scope of practice, and specifically issue number 11 on pages 21 and 22 of our committee staff report.
I'll give it to you.
Nursing.
Okay. Page 22?
21, 22.
21 and 22.
This has to do with the issue of Diastat. I think the statement in there is that, quote, has been traditionally restricted to the practice of nursing is, end quote, is not true. Diastat is an FDA-approved emergency medication that can be used by people without any training, and I was just wondering what the position of your board has been on that issue.
That's been a very controversial issue. We've had a lot of public testimony from parents, and we've heard from the school nurses, and we have met with the Board of Education to see where we can come to terms with this issue. We have statutory and regulatory guidelines for the administration of medication. This medication is ordered by a physician. It is a sedative. There are known side effects. The problem with administering a medication when you do not have the education, training, and experience to note for side effects is that when side effects do occur, they may not be assessed right away, and life-saving measures may not be instituted right away. So it is a position of the Board of Registered Nursing that patient safety is above all else, and we would not feel comfortable supporting positions that allow non-educated, non-licensed personnel to provide medications which could alter protective reflexes and result in complications and death.
So do you dispute the FDA's approval of a device that can be used by non-medical personnel?
Absolutely not. The FDA is within their bounds to approve lots of medications, equipment, applications.
You've taken a contrary position, I believe.
We are a regulatory board, and as such, we have legal input as to what is included in this act, and this is what we go by.
All right, thank you.
You're welcome.
First, I'd like to thank the chairman, Senator Curran, Senator Price, for holding these hearings. I think this is something I wish we'd do a lot more of. We're in what I call a bill factory, and at a time when this state has so many crises in so many ways, we should be doing more of this, and I appreciate the chairman's doing that. I also want to say I appreciate the work staff has done. I think you've outlined a lot of issues with recommendations, and I just wish we had more time to work on this. I had a question or an observation at the beginning, and that is, we're talking to you, and I think you all are working very, very hard to do a good job. It's very clear from all the comments that you're very familiar with all the issues and all of that. Something that I've championed for a long time is outside independent audits like our auditor does. And the purpose of that would not be gotcha, but the purpose of that would be sometimes to illustrate when you have greater needs, and what you've described is greater needs in all kinds of areas. But it gives an independent set of eyes. And the other thing I think would be good is to see that you are supervised by others in the department. could you just briefly tell me how active their supervision would be? And well, let me say it this way. I won't even ask you that question. In a normal organization, their supervision would be great. And the situation that happened that resulted in the LA Times article would never have occurred, because there would have been someone in the department which would have seen this issue, worked with you, made this issue public, said, what can we do to support the board? That's what I'd like to see. And then I just have a couple of other comments. And the main one is nursing shortages, nursing training, nursing education. And this is something in my 11th year here that I've focused on. I think, and I know the next panel will do more, we have done, and it's not your area, but we as a state have done such a poor job. It is, I don't even know what words to use about how awful it has been, because here's the reality. The reality is young people every year go to a school in the state, a public school, and say they would like to go into healthcare. And hundreds and thousands are turned away unnecessarily. And that is because the public education system has failed. It has failed miserably. And when we talk about diversity, when we talk about programs that could elevate a lot of these young people into the middle class and into a profession, we have failed them. And instead, we have imported from other countries who see how horribly we're doing this job and have training. Hey, there's a vacuum. Let's train them in our country and send them to the United States. And what we've taken is young people, and this is especially important, I think, in the diversity issue in minority population, and turn them away. It's not your problem. I'm just spouting off. And the other thing that we've done is talk about these private colleges. Well, I come from the private sector, and under normal circumstances, I say more power to them. I do in this sense, but they only exist in every field, because the public system isn't giving what people want. And so you should have, I hope you become advocates for that, because when I walk into my doctor's office, I walk into, if I have to get a test, I always ask them where they got their training and how much they're on their loan. And I would bet in this state, half of them have gone to the private system. And I always ask them, what happens? Well, you know, I went to my community college, and they said, gee, the backlog is 3 years and sometimes 4, and they don't have the courses when you get in. So I think this is something that in this state we really, really have to get on, because you're right, as the population gets older and as we spread medical care, the reality is nurses are going to do a lot of things that right now primary care docs are doing. So, you know, I support what you're doing. I just think we need to figure out a better way to get more of our young people who want to go in those jobs. And I hope as we try to do that, that you support it.
Definitely. Any other comments? Ladies, thank you. Testimony, and keep up the good work. Got a lot of work to do, and you're doing it well. Thank you. Thank you. Okay, our next panel will be up discussing the status of nursing shortages, education, workforce development, and of diversity within the nursing profession in California. And I think Senator Wyland really framed the discussion
it's a big deal.
Well, it's a big deal for all of us. We know certainly with the advent of health care reform, there's going to be tremendous opportunities, certainly pressures, but opportunities to deliver the kinds of medical services that we all deserve. Nurses, we know, play an important role. Yet we hear there's a shortage, that they're not enough, that people are being turned away. How can we reconcile? How can we address? How can we find some clarity in this issue? Who's up first? Joanne Spetz?
Yes. Yes. Hi. Good afternoon. My name is Joanne Spetz. Is this on? Yes, it's on. Good. My name is Joanne Spetz. I'm a professor at the Philip R. Lee Institute for Health Policy Studies and in the School of Nursing at University of California, San Francisco. I'm also a faculty researcher at the Center for the Health Professions at UCSF, along with my colleague Catherine Dower. We were asked to talk about the status of nursing shortages, education, workforce development, and diversity in California, which are clearly pertinent issues. For full disclosure, I have been the principal investigator for contracts that have been awarded by the Board of Registered Nursing to UCSF to conduct their annual survey of nursing schools, their surveys of registered nurses conducted every 2 years, and their forecasts of the RN workforce, and other studies as requested by the board and the executive officer. I'm also presently the recipient of a grant from the Gordon and Betty Moore Foundation to conduct a survey of California employers of RNs. And finally, I was the principal investigator of the National Sample Survey of Registered Nurses, which is conducted by the U.S. Health Resources and Services Administration. So that's my disclosure. But I'm drawing from the knowledge of all of these studies, but today I'm representing myself as a faculty member at University of California, and anything I say should not be construed as representing the positions of any of these other organizations. So I'd like to start by talking about the status of California's nursing shortage, which has been a big issue for many years. The most recently published forecasts of supply and demand of the nursing workforce were completed in 2009 based on data from 2008. The data were from the very first months of 2008, which means that they were from the very first months of the recession. And that's very important because it was also before the Affordable Care Act passed. There have been a lot of changes since March 2008, as we all know. At that time, we forecasted that the demand for registered nurses would continue to rise, both due to population growth and the aging of the population, and at that time, the supply of nurses in California also was rising. It was estimated that if the expansions of RN education that had been obtained to that date were maintained, California would reach the national average of RNs per 100,000 population in the mid-2020s, which is pretty impressive, going from number 50 to number 25. Big improvements. Since those forecasts were published, the recession hit and the Affordable Care Act passed. The recession seems to have had two effects on the shortage in California. First, it's depressed the demand for nurses. Many people have become unemployed and they've lost their health insurance, and people who have retained their health insurance appear to be more careful about their discretionary spending, so elective procedures that have copayment costs have declined and that sort of thing. Second, the recession has led nurses to increase their employment. In other words, the share of licensed nurses who are employed has been reported nationally to have risen. My comment is, if your spouse was in construction, you're probably working an extra shift. Nurses who were working are more likely to be working full-time. Nurses who were unemployed previously are more likely to have returned to nursing work. And the combined effect of the demand and the supply changes has been, right now, there appears to be a lack of positions for newly graduated nurses in some regions of California and in some parts of the United States. This isn't uniform. This isn't a uniform situation. There's still some parts of California where I've heard every nurse who's graduated from the community college had a job before they graduated, and some parts of the country where there still is a very severe shortage, but in other parts of California, you hear about new graduates finding it very hard to get work, and if they're not willing to move to other places where the jobs are available, they can be unemployed for quite a while. Now, I don't think this situation is permanent for three reasons. First, as the economic recovery continues, demand for healthcare services should return, and it also will grow with the growth of our population and the aging of our population. Second, as nurses' spouses regain employment and nurses' savings and retirement accounts are replenished, they're going to reduce their employment. They're either going to return to part-time work, or some are going to retire entirely from paid employment. Third, the implementation of the Affordable Care Act is going to bring about 3.4 million Californians into health insurance, and that growth in health insurance enrollment should increase the demand for health care services above and beyond what we have forecasted previously. In June, we're going to complete revised forecasts of RN supply and demand for the under our contract with the Board of Registered Nursing, based on the 2010 survey of RNs, the survey of RN employers that we're conducting with support from the Gordon and Betty Moore Foundation, and then other data that'll be available. So we should have some updates about how we think the recession is impacting things now and how we think the Affordable Care Act will play out in the future. So I'll speak briefly about the state of the RN education and workforce development, and this has already been discussed, so I'll skip over some of my planned comments. We know that there has been significant growth in RN programs between the 2000 and 2001 academic year and 09-10. The programs grew from 97 to 139, so depending on what time period you look at, you get 40 or 50, or it's a lot of programs that have been approved over the past decade. There are now 22 more programs in public universities, which is about a 25% increase, and about 20 more programs in the private sector, which is more than doubling of the private colleges in California that offer nursing degrees. Over this time, nursing enrollments more than doubled from 6,128 to 14,228, which is 132% growth. And graduations have grown 122%. Graduation should end up at about 132%, but those new enrollments need a couple more years before they graduate, and then those numbers will be higher as well. Despite this growth, we know that there's a lot of applications that are not accepted. The 2009-2010 school survey indicated that 65.4% of qualified applications were not accepted. And I think we need to be very careful that those applications may not represent individuals. A lot of people applying to nursing programs know that these programs are impacted and are applying to 2 or 3. And we have no independent count of how many people didn't get into any program. I wish we had that, but we don't. So all we know is that nearly 2/3 of applications were not accepted, but we don't know individuals if that amounts to 1/3 of the people or half the people or none of the people. We really have no idea. We think it's still higher than it should be. Given this demand, obviously, it could be argued that the RN program should continue to expand, but I do think we need to be cautious about talking about that expansion for 2 reasons. First, we know California has been on a trajectory for strong growth in RN supply based on this more than doubling of number of enrollments and graduations. And in 2009, our forecast, as I noted, indicated that we were on a trajectory to meet the national average of RNs per population, which has never happened in like all the data I've ever looked at over 50 years. And that doesn't mean we should be making our education system smaller, but we should be careful not to let supply grow so much that we end up with unemployed nurses. Unemployed nurses are unhappy people. It's just not good. You invest that much money in your education and you can't find a job. So I think we need to be very cautious. The second reason I think we need to be careful is that changes in our healthcare system and the implementation of the Affordable Care Act may change the knowledge that we want RNs to have. For example, some people anticipate that the demand for nurses in advanced practice fields like nurse practitioners is going to grow more than general hospital nursing positions. And we also know that there is a need for more faculty, which is a graduate level education. So in order to have more graduate level nurses, we need to be thinking about bachelor's degree nurses who are prepared to enter graduate programs. In fact, the Institute of Medicine's Committee on the Future of Nursing recommends that 80% of RNs should have a baccalaureate degree, although they did not necessarily recommend that 80% of newly licensed nurses be at that level, just that 80% get to that level. Now, we could debate whether that target makes sense for our state, because, of course, that was a national recommendation that did have an evidence base behind it. But, we could debate what our needs are within California, but I don't think we would debate that California nurses need a high level of knowledge and skill, and that we should be very deliberate about expansions of programs in order to both meet the educational opportunity goals of entering nursing as well as the healthcare needs of our population. In order to make sure we meet these needs, I think we need to talk about the opportunities nurses have to advance their skills. We've talked a lot about growth in programs for pre-licensure education, but there has not been a lot of focus on post-licensure education, meaning you have an associate degree, you want to get a bachelor's degree. How do you go about doing that? What kinds of employer support, what kinds of programs are available to you? How long will it take for you to do that? What if you want to get a master's degree? Do you need to spend 2 more years on a bachelor's and then 2 more years on a master's, or can that be streamlined? We know also that there are a lot of people who enter their first RN education program having already completed post-secondary education. About 60% of our nursing graduates have completed some other post-secondary education before they start their RN program. So they already have an associate degree or bachelor's or master's or even doctorate. And 24% of our nurses initially had, wrong number. We have 40% had previously worked in some kind of health occupation previously. So we have a lot of nurses coming into nursing with other experience in education, and we need to think about leveraging that effectively. Given that we expect growing demand for advanced practice nurses and greater skill of nurses in general, I think we need to really talk about these strategies to help people advance carefully. And there are a number of financing sources that we can think about with respect to that. Health Resources and Services Administration and the U.S. Bureau of Health Professions has grants for nursing education through their Division of Nursing, and those priorities have historically been in the areas of graduate education and diversity. California received over $126 million last year from 230 grants, and that was across all health professions. I couldn't quite get the data system to give me nursing very quickly. But it's expected that these funds will increase due to the Affordable Care Act. There's a lot of line items in that act associated with expanding health professions education. There are also expansions of things like community health centers funding, which should increase demand for nurse practitioners and so on. And also even support for internships and nurse residency programs. The Affordable Care Act also makes note of programs aimed at improving the diversity of the health professions, which has been mentioned by this committee as being something to consider. The diversity is an important topic, and the nursing workforce in California is more diverse than other states. About 40% of our RNs are non-white, and about 14% are male. Nationally, only about 7% are male, so we're at double the national rate for men in nursing. But probably what's more important in thinking about diversity is not the overall population, but the new graduates, because those portend what our workforce is moving into in terms of diversity. So in 2009-2010, nursing programs reported that 60% of their new enrollees were non-white, about 18% Hispanic, 16% non-Filipino Asian, about 16% of Filipino heritage, which is distinct from internationally educated nurses who are immigrating from the Philippines, and about 6% are African American and 19% are men. So there's still a lot of underrepresentation, particularly of men and Latinos in our nursing schools, but there has been a lot of progress, and that's something that we should be looking at very carefully. Increases in the numbers of racial and ethnic minorities is largely dependent on K-12 education. We need to have a pool of people who are prepared to enter community college and baccalaureate nursing programs who have the right preparation coming out of high school to tackle a challenging scientific curriculum. We also need to think about the financial support that those students would need in order to enter programs, because for many people, even a community college education is extremely expensive, not even to begin to think about the private colleges. So in conclusion, our nursing workforce has changed markedly over the past decade in its size and diversity. We have many more graduates. We have many more diverse graduates. And we want to make sure that we sustain that growth that we've obtained in nursing education, and not let the current reports of unemployment take our eyes off the ball. If we allow programs to shrink, we could very easily end up in a very, very severe shortage situation as the nurses that now are delaying their retirements end up retiring and the healthcare needs continue to expand in our state. So we need to be thinking about growing the demand for more highly educated nurses and focusing on the social and economic need to expand the diversity of our workforce. Thank you.
Thank you.
Good afternoon, and thank you. My name is Catherine Dower. I'm the Associate Director of Research at the Center for the Health Professions at the University of California, San Francisco. And I'm going to take this opportunity to build upon some of the comments that Joanne has offered, particularly in regards to workforce development and professional regulatory issues in a broader context. So my comments are framed not only from the work that I do at UCSF, but also in part from having recently served as one of the members from California on the Robert Wood Johnson Foundation Committee on the Future of Nursing at the Institute of Medicine. So Joanne also already made some comments, some reference to some of the recommendations that came out of the IOM on nursing. And I would underscore that this was not a political effort, but a scientific, very rigorous, evidence-based effort. The IOM committee made 8 major recommendations about nursing with over 40 specific sub-recommendations. And the IOM did not make any recommendations regarding supply or shortages of nurses. So one takeaway message is that more than ever before, we need to be nimble in our approaches to education and staffing. And truth be told, even with the high-quality research that is available, we don't know what the future holds in terms of demand or supply. Our estimates and our predictions are imprecise at best. We need to find ways to be able to scale up and down, again, in both education and staffing, as needs and environment shift. So one of the environmental shifts has been the passage of the Patient Protection and Affordable Care Act. And one subtle but significant shift that we see in that federal legislation is a clear federal awareness of and interest in the health workforce. So for the first time ever, we have a National Health Workforce Commission that's been established. It's going to be headed up by a nurse. And we know that nurses, like other workers in the United States, move around. So it's going to be important for California to build upon the good data collection efforts that it has undertaken in the past to coordinate with national efforts to track supply and contribute to the national efforts to better understand demand, which we don't really understand completely yet, within and among the states, because there is a lot of movement. Another shift in the environment, driven by factors ranging from the IOM report to the Patient Protection and Affordable Care Act to market forces, is a focus on finding new ways of doing things. So I'm going to touch on 3 of those new approaches. First is a look at innovative practice models. So, for example, nurse practitioners today in California and across the country are providing primary care that in the not-so-distant past was the exclusive domain of medical doctors. And similarly, some nursing assistants, medical assistants, community health workers, promotoras are providing services that historically were only done by RNs. We're likely to see more innovative practice models, which will have different staffing profiles in the patient-centered medical homes and in the accountable care organizations, 2 types of practice and financing models that are encouraged by the PPACA. I would underscore that both of these phenomena, though, the medical homes and the ACOs, are moving forward here in California in particular, with particular speed, with or without the support of the PPACA. So they're going ahead. A second example of new ways of doing things will be the increased use of technology and telehealth in health professions, education, and practice. In 1996, California was seen as a leader in writing one of the first telemedicine laws in the country. Without a significant revision to that law since then, however, it's now pretty dated and outdated compared with other states. A proposed new model telehealth act for California was released a couple of weeks ago, which could affect and improve how all health professions are regulated in the state, and it's important for us to take notice of that. A third example of new ways of doing things are continuously expanding and evolving legal scopes of practice for the health professions in California. And for nursing, this is particularly important. Again, while California is unique in the United States in that we have a mechanism in place to test expanded scopes of practice, we're the only state that has something like the Health Workforce Pilot Project, where we can test an expanded scope of practice before the law is changed. And it's been used quite a bit for nursing to the benefit of patients and the profession in California. But even with that, today California is about in the middle in terms of authority for nurse practitioners and other advanced practice nurses to provide services that they were educated, trained, and tested to provide. So in addition, because of the state-based way that we regulate health professionals in this country, we have this patchwork approach of laws that don't serve patients or the profession. Considerable variability across the United States. For many years, many people recognize this problem. It's been acknowledged that it's a problem for patients and for employers and for practitioners, but we didn't have a model to point to for a more standard practice act. However, recently, unfortunately, an APRN consensus model that was developed by multiple nursing associations has been produced and released and is being implemented. This is a model that the Institute of Medicine did point to for the states to consider in revising their practice acts for advanced practice nurses to better recognize through standard means the competence and capacity of APRNs to meet the needs of patients across the country. So I'll conclude by saying that California has a long history of both strong regulatory systems and innovation in healthcare delivery and financing, and today is no different, but we must also be aware of and responsive to trends beyond the state. We can be thoughtful in our approaches to collecting data, to regulating telehealth, to shifting from continuing education to continuing competence, to establishing laws affecting the practice authority of healthcare professionals in California that can build upon the state's strengths and also accommodate and coordinate with promising national efforts. So I want to thank you now for your time. I think Joanne and I are both available for questions.
Thank you.
Thanks.
Members, Mr. Weiland.
Thank you for that testimony. That was really illuminating, very well done, and I appreciate it. And again, I just wish we could spend more time doing this rather than see the plethora of bills that we're going to see. I know we find it amusing, but it is true that we spend most of our time, and few people realize, that what do we see in a year on both sides? A couple of thousand bills are introduced, and it's striking to most people. Many of those in the audience are very familiar with it. You just covered a lot of really good things, I think. One of the things that I mentioned, and I appreciate Senator Price's indulgence in my getting pretty excited about it, but for a decade or more, I've been concerned about availability of these programs to young people. And when we talk about diversity, especially ethnic diversity, it seems to me that this is one of the ways in which many young people who ultimately can have the skills can emerge into the middle class and become professionals. I think you really put your finger on something very important when you mention K-12 education. And unfortunately, and it's true in virtually every one of these types of professions, this is almost every job and profession, a lot of that money's been put into the community colleges. But it doesn't recognize that first you have to graduate from high school and you have to have some degree of training. I've seen in my district one high school that's attempted to do that, and they've done it reasonably well, enough so that someone could, with help, and I think they need help, get into one of those programs and do well. So, and I understand what you're talking about need, demand versus supply. I still think, as you pointed out, it's variable in parts of the states and part of the country. I hope that I think we can rely on your research, and I hope you get more of it and more contracts, because it's really helpful. And I think one of the biggest jobs we have is to get our system to figure out a way to get more of these young people who want to in these programs. So thank you very much.
I agree. I think the new health legislation is going to provide an exciting opportunity, certainly for better health, but for some real unique career opportunities, particularly when it's our youngsters who are coming up and who can play a real active role. And so we just appreciate your comments. None other? Okay. Well, thank you, ladies. Thanks for your comments. We're going to move to the last panel. Kelly Green from the California Nurses Association, welcome, and Laura Brown, the Coalition of Accredited Career Schools, and anyone else that would like to join us for commentary. Okay, if you just wait your turn and you'll have an opportunity. How's that?
Thank you, Senator Price. I'm Kelly Green with the California Nurses Association, and we appreciate the opportunity to provide feedback at today's hearing on the staff recommendations and the Sunset Review, as well as general issues affecting the Board of Registered Nursing and the profession itself. One of our main concerns regarding the board, and which has been talked about at length today, is the board funding and staff. And obviously the board's addendum report and the committee's background paper point out the challenges that the board faces with regard to resources. We appreciate the committee and staff the acknowledgement that the lack of resources really does hamper the board's ability to enhance its regulatory function. This is an area that we have focused on greatly over the last 2 years since the board has really been placed under a lot of pressure to reform its enforcement program. Numerous enforcement-related proposals have come forth since the publication of the LA Times articles in 2009. However, simultaneously, the board has been subject to program budget cuts, staff furloughs, hiring freezes, which have really severely curtailed their ability to implement changes to their program or take on additional responsibilities. Our organization, CNA, is of the position that with its limited resources, the board should really continue to focus on streamlining itself from within in regards to its current set of responsibilities before it's required to take on additional responsibilities that are not central to making the current enforcement or regulatory processes more efficient. Further, we do not support the borrowing from the board's fund reserve in order to augment the state's general fund. This is a position that we've we've been consistent on. Registered nurses have recently had their license fees significantly increased with the primary purpose to provide additional resources to the board's enforcement program. We want to make sure that those special funds remain with the boards, that it can achieve its regulatory mission, and as such, we do appreciate the committee staff recommendation to stop loans from the BRN's reserve fund, especially in light of the recent fee increase. With regard to enforcement, again, we want to make clear, and we appreciate the work of the committee to understand the lack of staffing, as well as its reliance on other parties like the Division of Investigations, the Attorney General, the Office of Administrative Hearings. All of that impacts the ability for them to streamline their enforcement process. There are a couple of specific enforcement recommendations that I wanted to briefly touch on. One is in regards to giving the board greater authority to access records pertaining to investigations, which include medical records. We are generally okay with this recommendation, but one position that we have held is we want to make sure that registered nurses are not held liable to turn over documents during an investigation that they do not own or control. And as employees, those documents could range beyond medical records. They could be staffing logs, they could be electronic tracking, it could be timekeeping. Whatever documents are pertinent to an investigation, the registered nurse, again, generally as employees do not have control. We would like to see that they're not held liable or somehow disciplined for unprofessional conduct in those cases. We do continue to oppose proposals that require the reporting of arrests to the board. This is something that raises due process concerns for us. There are circumstances in which nurses, for example, public protests, they may be arrested, or cases in which arrests may occur. There's never any subsequent conviction. And so forcing the licensee to report that arrest to the board, we feel, is unfair and punitive. With regard to employer reporting and with peer review, we have maintained a consistent position opposing employer reporting. We think it puts the board in a difficult position to substantiate private disciplinary actions, particularly at a time where the board and its resources, they're having a difficult time keeping up with their current caseloads. So that has been our position on that. With regard to peer review, we think it's a little early to formulate a position. As part of the National Nurses United, which is a national nursing professional association and union, we have 160,000 members across the country. We have heard reports of some problems with nursing peer review processes in other states, and as such, we'd like to learn more about what the committee envisions regarding peer review before we can take a position. With regard to the diversion program, we want to reiterate strongly our support for the program, and we think that it is vital to getting nurses with substance abuse problems into recovery and rehabilitation. We are concerned with the context in which problems with the diversion program are raised, and if Senator Vargas were here, I would echo his comments. We are an organization that believes in second chances, and we would want to reiterate the success rate of the diversion program with over 1,500 have completed it. I understand that their current completion rate is over 60%, which is an increase of 10% since 2005. I also want to reiterate that nurses who enter diversion are not working at the time. Their licenses are inactivated, and that really is an important piece in eliminating the potential risks to patients while allowing nurses to focus on their recovery. Lastly, diversion is not subsidized by the state. It's paid for through nursing license fees. Is the program perfect? No, it is not. We do think that improvements can continue to be made. While we have some concerns over the amount of staff time that may have to be dedicated to additional audits, we just want to make sure that if audits are forthcoming, that they focus on continued improvement of diversion, that they are not used as a tool to undermine the program in any way or to find a way to eliminate it and go solely to a disciplinary model. With regard to uniformity and uniform standards for licensees on probation or in diversion for substance abuse, we've taken the position that we think that boards should retain some flexibility in determining what standards are appropriate to fit their profession and what standards are appropriate to fit the individual licensee in recovery. Complications with uniform standards have already arisen with regard to the number of tests is one example, and we think that something as sensitive and as individually unique as substance abuse, that the board should be able to retain some flexibility and authority there to determine what's best for the registered nurse, and then in turn that would determine what's good for the patient. I will close with just some brief comments on other key areas of the background paper. With regard to workforce and diversity, we do appreciate the presentations just made. I have to say, and this may be an unpopular position with some in the nursing community, but we are concerned and cautious about recent proposals in the nursing community to move towards or create a situation in which the vast majority of nurses should move into a baccalaureate degree program as opposed to an associate degree program. We appreciate the distinction that was made in the prior panel that the IOM report isn't suggesting that we have the majority of the nurses start off with going for a BSN degree, and that there would be some consideration given to try to encourage ADNs to move into BSNs. But we do question the necessity of such proposals. Our organization and the nurses in our organization have taken the position that there really is one point of entry to becoming a nurse, and that is the NCLEX exam. Whether you're an associate degree nurse or a bachelor or a BSN, that the NCLEX exam is what you are. That's the test to become a nurse. We're very concerned about unintended consequences of moving into a movement towards baccalaureate degree, a stronger emphasis on that with regards to accessibility of programs, affordability of programs, and we don't want to inadvertently take away from associate degree programs, particularly in the area of diversity in the nursing profession. We think that those programs are vital to allow individuals to enter into nursing education, and we want to maintain as much support for them as possible. With regard to public programs, we absolutely agree. We think that there needs to be more focus and support placed for our public education programs. They are an affordable way to obtain a nursing education. Just a couple of other areas. With regard to scope of practice, we do not support the staff recommendation that consideration be given to authorize unlicensed personnel to administer medications to students on campus. This is an area that we just remain philosophically and staunchly opposed to, primarily for the concern of the health and safety of the student. Insulin and Diastat are dangerous medications. We believe that these and other medications need to be administered by trained and licensed personnel. They can properly assess the medical needs of the student, and they can properly respond if an emergency occurs. We believe that there really needs to be focus on a comprehensive solution to this issue because the health needs of students in California, it's diverse. They're acute. They're not limited to diabetes and epilepsy, and we don't think that taking a piecemeal approach to the problem by drafting a bill for specific types of medicine that are needed by students is a way to address the problem. We think that we need to try to focus on creative ways to ensure that licensed and trained personnel are available to those students so that students with medical needs really do have access, unhindered access to equal education. I think given the time limitation that we have, I'll end there. I would like to make the committee members and staff make myself available if there are further questions. We have positions on almost all of the recommendations put forward in the report, and I'd be happy to talk further at a later date.
All right, thank you. If you have some written material that you'd like to present, we'll be happy to receive that as well.
Thank you.
Thank you,
Ms. Brown. Let's let Ms. Brown go, and then I'm sorry.
Thank you, Mr. Chair and committee members. Laura Brown on behalf of the California Coalition of Accredited Career Schools. Thank you for having me today. I'd like to speak specifically to issue number 5 outlined on page 14 of the agenda. As the background paper indicates, the BRN is considering the idea of requiring accreditation for all nursing programs. And while we fully support accreditation and believe that this would elevate the quality and integrity of an institution, we have particular concern with the proposal to require that the BRN only consider accreditation by WASC or its regional counterpart. The idea of carving out a nationally accredited institution has no policy merit or foundation, and we believe that that would in fact create a monopoly of accreditation serving no legitimate purpose. We're not sure that this is where the BRN wants to go. We understand that there are going to be 4 public hearings around the state convening pretty soon, I believe mid-month. We think the genesis of the proposal came from the idea of transfer of credits. And we just point out that the issue of transferability of credits cuts across all sectors of higher ed, regardless of the source of accreditation, whether regional or nationally accredited. And many of the disputes regarding transfer credit involve publicly, regionally accredited community colleges and state universities, and frequently involve students from one regionally accredited institution attempting to transfer their credit to another. So the requirement of regional accreditation only would obviously not not fix that issue. So again, we think that all, as Mr. Weiland said briefly, that we're trying to increase access to nursing ed programs. We think these career colleges provide a valuable source of education, and we would ask that the committee, if this is the way that the BRN wants to pursue a proposed amendment, we would ask the committee to caution the BRN on its desire to carve out nationally accredited institutions. Thank you.
Thank you.
Thank you, Mr. Chairman and members. Brooks Ellison on behalf of the United Nurses Association of California, Union of Healthcare Professionals. In the interest of time, I think we would say we agree with I think everything that Kelly Green said on behalf of CNA, but we'd like to maybe focus on the one area of the funding and the borrowing. I think there's 384,000 nurses, and essentially what they were told is there was a problem that was so bad that their fees essentially would have to almost be doubled. And if that didn't happen, what you would have is a fund that might be bankrupt and that you would have health care concerns. In other words, people could be injured, people could die, et cetera. And so, people stepped up. And when this debate was going on about the fees, there was some skepticism, I think, in the industry of what might happen. In other words, you really wouldn't use the money to fund the staff that was requested, and, there's some things that you wouldn't do, and that the state would probably borrow that money. And that's the way it's looking now. That the earlier testimony, they asked for 63. They received authority for 37. They've made 0 in terms of new staff hires. But what you have is a hiring freeze, furloughs, 5% reductions, and a $15 million loan. And that really puts it in a difficult position when you tell nurses, it's so bad we're going to double your fees, but then you don't do any of the things that you said it's so bad that we're going to do. It's hard to go back to the membership and stand up before them and say, well, look, I know your fees were doubled, and I know this is what we told you, but we didn't use the money. That raises an issue of trust, and I think the next time you want to use the fees and you want to increase them, people are going to say, well, the last couple times you did this, here's what you did. And so I think you have to either use the money the way that you said you were going to use the money, or suspend those fees. We're not advocating suspend the fees. What we're really advocating for is don't borrow the money. Use it for that purpose. We understand that a lot of other boards and commissions are borrowing, but it's our understanding, I appreciate staff's report, that more of it's coming from the BRN than any other department. In other words, the one where people have said the biggest problem's been, the most money seems to be coming out of that fund. And that's, again, hard to justify. So we get these are difficult times, but we would really urge the committee to take the position to, at least in this instance, not agree to that borrowing. It's a special fund. We understand there is litigation going on about whether that you can actually do it out of this fund, because there's a government code section that says if you're going to impact the fund, you shouldn't borrow from it. We clearly think that when you make the finding of what would happen and the reason for the fees, that's clearly the impact statement that you have. So I would close with that, but really ask you to not support that. Thank you.
Thank you.
Tricia Hunter, American Nurses Association, California, and I'm not going to repeat the discussion that already has gone on. I want to make a couple statements about diversion. I actually had the opportunity to testify with Betty Ford in 1986 when we passed the first diversion law for nurses in the state of California. And though we don't have issues with independent audits and independent looking at the program, we do think the program needs to be funded before we start coming in, and we already know there are issues with not enough staff at the Board of Registered Nursing to be able to implement the programs they're involved in. We know they have a shortage of staff within their discipline and diversion program. We know that they're working long hours of overtime despite furloughs, cost cuts, cuts to their salaries, and all the rest of it. They're working the overtime that I think has already been stretched to the limit it can be stretched. And again, we think the funds that were designated to both deal with the discipline and the diversion program should be spent to be able to make both those programs whole. And then if an ongoing independent audit is something that needs to be looked at, I have no doubt the Board of Registered Nursing would be able to function fully at where we would want them to be with that kind of an audit. I also want to remind the committee that the contracting process in the state of California has criteria that requires them to take the lowest bidder. Many of the times the not-for-profits, when they show up to bid on these programs, don't have the ability to cut at the level for-profit bidders do, and that I, again, don't have an issue with having a not-for-profit run the program, but then we're going to have to change something in the bidding process as to who can successfully bid for those programs, because many times the not-for-profits cannot financially compete at the level that some of the other bidders can. I do want to touch on the approval process of programs. I've actually personally been involved with a couple schools that have gone through the approval process of the Board of Registered Nursing. If you follow their criteria, it is a very fast process. I've gotten a feasibility study through in the first try and a self-study through in the first try. And the bottom line is that you have the appropriate people, i.e. a director of nursing that has the qualifications to be able to write a curriculum, and you follow the steps that they propose, and you can get a program through that process. I've seen some of the feasibility studies and a lot of the testimony of different programs that have been at the board proposing to open programs, and at least at the presentation they gave, there was a lot of reason why they didn't get through the feasibility study and hopefully not the self-study till they got to the point that they were able to put together a decent program. The process is very clean, it's very clear, and it doesn't make any difference whether you're a for-profit or not-for-profit program. It is very clear process to go through, and I do know there's a program here that will testify that went through the process and has an outstanding program in place now. I also wanted to just touch a bit on what happened with the Board of Registered Nursing and the LA Times. It was public that the board was behind in their discipline. It was reported at every board meeting. There were ongoing meetings with the Department of Consumer Affairs. It was in the sunset hearing report that came before this committee the last time. So the fact that the board was behind in discipline was very public. But you also have to remember it's very political, that the Director of Consumer Affairs works directly for the administration, whichever administration we're talking about, and that the Board of Registered Nursing is under the Department of Consumer Affairs and does have to report to them specifically related to their budget, and that you are not going to find, I don't think, a board that survives too long that becomes in an adversarial position with the Department of Consumer Affairs, or a Director of Consumer Affairs that's going to survive very long that gets in an adversarial position with the administration. And so there are politics that plays in how far those boards and the department have in their ability to make it too public. But the reports were there, the information was given, it was very transparent what was going on with the discipline process of the Board of Registered Nursing. And so I just want to again remind this committee that you do. I don't know how we resolve getting the 32 positions approved. I mean, they are approved. I don't know how we get them released. But if you don't have the staff to implement the programs, you can audit till the end of the earth, and you're going to get the same results. And so every program that the board brings forward, the approval process for schools would go faster if they had the NECs to look at them. The discipline process would go better if they had the staff to implement the program. The diversion program would be better if they had the staff to stay on top of it and even do their own internal audits until an outside audit was done. And then I just want to touch a little bit on the education. I was so disappointed listening to the Higher Education Committee here a few weeks ago, where one of the school administrators got up, and when he was asked how he addressed the change in what was happening in his communities and the type of programs were needed, and he said that he used the nursing programs as an example and said because the schools weren't hiring, we've decreased our nursing program. And we're hearing that throughout the state of California. The public schools are decreasing their nursing programs throughout the state. And we believe strongly with the statistics that have been provided. I know one hospital that has shared with us that they believe 60% of their nursing workforce is retiring within the next 2 years. It's nurses who have chose to stay on because of the economy and who are going to retire when the economy gets better, or as someone else said, their spouse goes back to work. And nursing programs are expensive. At the community college, they cost a great deal more than it costs to have a history program or a literature program or an English program. It is very difficult to get those positions reinstated once they're gone. Most of these positions were created with extra funding that the last two administrations put aside money to allow these schools, additional money to allow these schools to increase at that time. We go back to another period where we're going to be looking for funding for these programs, and it's very hard to find. There is a couple things we are strongly supporting. One is a differentiated fee for the nursing programs at the colleges, whether it's a state program, university program, or the community college. But then there has to be a mechanism to make sure if you're going to charge people extra money that the money goes back to the programs, that it doesn't go into the general fund as it would right now. And then we are also supporting the concept of a bachelor's degree at the community college. And when I say that, I want to be really clear, because most of the community colleges don't want to provide an actual bachelor's degree. But the reality is there's no such thing as a 2-year nursing program. Nursing programs are a minimum of 3 years, and most of them are 3.5. By the time you get the prerequisites out of the way to be admitted to a nursing program, to take the 2-year ADM program, you have a 1.5 years of college. And when you aren't admitted to a nursing program to take that 1.5 years of college, you have no financial aid that is available for people who are going to nursing schools. Additionally, by the time they graduate, they have a bunch of hours, and none of them transfer at the junior or senior level. And so if they even had the ability to have hours with some of those extra classes like political science, history, whatever, at the higher level, the transition through the process of getting a bachelor's degree for many of them who choose to go on would be much smoother. The majority of our nursing programs, our nursing education is at the community college. It's not at the higher education level. Our community colleges are an important player in this process, and I think it's time we recognize that it's a 3-year program, not a 2-year program, and allow them to admit students to that 3-year program, however you creatively resolve that within the legislative process. And then finally, I just cannot stress enough the disappointment. I actually carried the bill that that allowed the board to increase the fees. The Board of Registered Nursing had not increased their fees since 1990. When I carried the piece of legislation that gave them this authority, we all agreed as licensed nurses in the state to support. We worked hard not to have opposition to that fee increase, which doubling our fees would usually have a major opposition to, and then to have that money pile up within the reserve fund, as well as the furlough days pile up in the reserve fund, and then now the additional 10% cut the board has been required to take, let alone the cut last year, and then to hear the board criticized is very difficult. It's difficult to sit in this committee and hear some of the testimony that's been given when the resources that we have provided for this board to be successful are not being allowed to use. As a nurse, I feel double taxed. I pay this extra money as a licensing fee, and it's going to be taken away to balance the budget instead of doing what the board is supposed to be doing. I know that isn't within your purview as a committee to deal with, but anything you can do in putting pressure through the budget committees, and that was one of the recommendations. And releasing the fees, the money from the fees, self-supporting, no state funding, we would appreciate. And finally, before I retire from the political process, I'm going to carry an initiative to remove the Board of Registered Nursing so that we can have an independent position like the chiropractors have, and so maybe our money can get spent for what our programs are. Again, I have no problem with the audits, no problem with the oversight, but do have a problem that the board isn't allowed to implement their programs.
Thank you. Next.
Nancy Spradling. I'm the Executive Director for the California School Nurses Organization. The California School Nurses Organization, or CSNO, supports the continuation of the Board of Registered Nursing as a regulatory program. I would like to make sure that you understand that school nurses are BSN, they are RNs, they have 27 units postgraduate specific to school nursing. And then they have a credential from the Commission on Teacher Credentialing. It is imperative that the BRN work closely with CSNO to address some of the issues which have a serious impact on the health and well-being of students in California. Credentialed school nurses must provide diligent care to all students in California public schools, and that translates to 6.2 million consumers that they have to protect. The demands have increased dramatically over the last few years. There are a growing number of students with chronic health problems such as diabetes, severe life-threatening allergies, mental health conditions, and asthma, as well as children who are medically fragile. The medical management of these children has become increasingly complex, with advances in medical technology and treatments that are requiring closer monitoring and more interventions on a daily basis. We're now seeing kids in school that have had transplants, kidney, heart, liver transplants, which means that they are now immunosuppressed. Although the demand for nursing services has increased, the trend has not been to increase the number of credentialed school nurses. Instead, many schools have turned to licensed vocational nurses or unlicensed and in some cases untrained assistive personnel, such as school secretaries, classroom aides, to staff health offices and classrooms where health services are required. This has caused a huge amount of confusion for many parents who believe that anyone in the health office is a credentialed school nurse qualified to provide care, education, and counseling on health issues. Many schools do very little to rectify this misconception. The credentialed school nurse has been required to train secretaries, clerks, or other unlicensed staff to administer medications when the nurse is not present. These unlicensed assistive personnel are being asked to give medication by a variety of routes, including orally, rectally, topically, through a gastric tube, by injection, inhaler, or nebulizer. In some cases, such as with the injections, inhalers, or nebulizers, unlicensed personnel are also being asked to evaluate the effectiveness of the medication and respond appropriately should anything unexpected occur. It is vital that the board be able to back these nurses when school districts make demands that are not safe and not appropriate and are not allowed under the Nursing Practice Act. CSNO appreciates the interest that the BRN has taken in looking at school health issues confronting credentialed school nurses, but much remains to be done. CSNO would ask that the Board of Registered Nurses work with the Department of Education to address these areas of conflict that make it difficult for credentialed school nurses to work both within their scope of practice and provide diligent care for California's school children. School districts need clear direction and oversight. The BRN needs to work with the Department of Public Health and the Department of Education to develop requirements for certification for these UAPs to establish a standard of practice which would provide consistency and quality across the state. CSNO needs to also be actively involved in this process and requests that the BRN reestablish the School Nurse Advisory Committee, which was in existence maybe 10 years ago, to provide a forum to address the provision of health care in California schools. Thank you for this opportunity.
Thank you. Thank you for your comments.
Good afternoon, Mr. Chair and honorable members. My name is Elizabeth Wong, and I am the president of the California Association of Nurse Anesthetists. CANA is an organization that represents over 1,400 certified registered nurse anesthetists who are dedicated to delivering quality anesthesia services throughout California. We are here to support two issues that are presented in the background paper. The first is issue number 25, and we're here to express our strong support for the Board of Registered Nursing and wholeheartedly agree with the staff's recommendation that the nursing profession should continue to be regulated by the Board of Registered Nursing in order to best protect the public. The second issue we would like to support is issue number 15. We are concerned by the lack of adequate staffing needed for the Board of Registered Nursing to investigate disciplinary matters and would like to support the staff's recommendations that are made in the background paper. Thank you for your time.
Thank you.
Good afternoon, Senator Price and other members of the committee. My name is Philip Bautista. I am currently a nursing student and the legislative director of California State Nurses Association. California Nursing Students Association represents 3,700 students across the state of California. And as students in a pre-professional organization, we recognize the importance of involvement early in the future of our profession of registered nursing. California Nursing Students Association is also in support of the Board of Registered Nursing as we recognize the need for a regulating agency to maintain standards and policies in the profession of nursing. Also to maintain safe and competent nursing care as we move and transition to the field of nursing. As students, we recognize the oversight of the board to ensure that the 148 pre-licensure programs throughout California are providing education that prepares the future next generation of nurses to continue to provide adequate, safe, and competent care through all the consumers in California. We simply give our support, and we thank you for your consideration and your time.
Thank you for your testimony.
Thank you. I'm Pat McFarland. I'm the CEO of the Association of California Nurse Leaders and the California Nursing Student Association. And you can see by evidence of Philip, we have a great future in our future nursing. They're diverse, and they are articulate, and they are some of our best and brightest. We need to continue to support our students. In respect for your time, ACNL supports the continuance of the Board of Registered Nursing, and thanks very much for the leadership that Louise Bailey has provided and the President Graves over the last 18 months. It has been truly a challenge. They have taken on some many difficult issues, have resolved them. They have collaborated with the individuals across the state that needed collaboration with, and they continue to move forward on a positive front. All's not done, but they are working in a very clear, direct manner. We are, like the other associations that have spoken, very concerned about the funding issues, and during the process of doubling our licensure, we verbalized much of that concern. So anything this committee can do in support of that to ensure that the board has the appropriate individuals and staff to carry on the work of the Board of Registered Nursing, we'd appreciate it very much.
Thank you.
Okay. Good afternoon. I'm Dolores Jones, the Executive Director for the California Institute for Nursing and Healthcare. This is a nonprofit organization that serves as California's Nursing Workforce Center. And as such, our mission is to ensure that California has the quality workforce we need to meet the state's need for nurses and to provide care to the people of California. The Board of Registered Nursing is our key partner to address our state's nursing workforce issues, most significantly the nursing shortage, and to develop sustainable solutions to build the workforce. You heard from Joanne Spetz a little while ago about the significant progress we really have made in the state of California working together. And through our working together, and I'm talking specifically about the Board of Registered Nursing along with the California Institute for Nursing and Healthcare, it becomes an important way and a key way that the board, the BRN, is able to fulfill its responsibility to ensuring that the state has the quality nursing workforce that we need. Louise Bailey, the executive officer of the BRN, is an active and critical member and my key partner in guiding the work of the California Institute for Nursing and Healthcare. And this includes Ms. Bailey sitting on the steering committee for the Institute, serving on our diversity committee in an advisory capacity to increase the diversity and the number of our underrepresented minority students. She also serves on our advisory group for the collaborative model of nursing education, which is the seamless progression between ADN to baccalaureate education. She also is serving on our advisory group for our Transition to Practice program, which is a community-based program for new grads that are, at this point in time, not able to find employment to increase their competencies and skills and increase their employability. She also is a member of what we have recently established as the California Regional Action Coalition, which has been charged to implement the Institute of Medicine's recommendation on the future of nursing and ensuring that California's nursing workforce is prepared for healthcare reform. In closing, I just really want to say the partnership that we have with the Board of Registered Nursing is critical to being able to directly influence the state's ability to provide a quality nursing workforce. And we very much appreciate not only Ms. Bailey's, but also the board's support in this important work. And thank you for this afternoon.
Thank you.
Good afternoon. My name is Ben Cavasi. I'm a science writer,